Have you ever stopped to think about what really goes on behind the scenes when a doctor orders an X-ray? I mean, it's far more than just pointing a camera and clicking, right?
Oh, absolutely. It's this intricate dance. Physics, patient care, knowing your anatomy inside out.
It really is. Radiography seems to blend that hard science with a deep understanding of the human body, turning invisible energy into this window inside us.
That's a great way to put it. A window.
So today we're taking a deep dive into this fascinating world of radiography. That's the art and science of creating these diagnostic images. We're going to try and unpack the essential steps, get into some intricate anatomy, precise patient positioning.
And even how different conditions, different pathologies actually change how things look on the X-ray.
Exactly. And you've given us a really rich stack of sources for this deep dive. We've got detailed study guides on the basics, general anatomy, specific chapters on chest and abdomen imaging.
Yeah, and comprehensive guides on how pathology alters those images. It's quite a bit of material.
It is. So our mission for you today is to try and distill all this knowledge into, clear, actionable insights, give you a real understanding of what it takes to make those vital diagnostic images. It's about seeing behind the picture, understanding the whole process.
Sounds like a plan.
Okay, so first up, who is the person behind the X-ray machine? We're talking about the radiographer.
Right. They're the technologists. They use ionizing radiation under a doctor's orders to create these images.
Sounds straightforward, but you mentioned skills. There's a surprising amount of expertise needed, isn't there?
There absolutely is. A radiographer needs, a really broad skill set. Think about it. They're applying physics principles to actually make the image.
Okay.
They need to understand complex anatomy and physiology, know what they're looking at, and critically, how pathology might change that picture.
So they're interpreting as they go, in a way.
To an extent, yes. Plus, they're masters of image quality assessment, critical thinking, especially for LRA compliance.
LRA, as low as reasonably achievable, the radiation dose thing.
Exactly. It's this constant balancing act. Get the best possible diagnostic image with the absolute minimum radiation dose to you, the patient.
And even before you, the patient, walk into the room, there's this meticulous setup.
Oh, yeah. Daily cleaning, prepping the room, the equipment before every patient.
It's not just tidiness, is it? It's fundamental safety.
Totally. Infection control 101, hand hygiene, using PPE, personal protective equipment, following specific precautions like droplet or contact protocols. It's all about preventing pathogen spread.
And the radiographer's watching the patient the whole time.
Constantly observing, giving clear breathing instructions, breathe out and hold it for an abdomen x-ray, or maybe take a deep breath in and hold it for the chest.
Okay.
And gentleness, patience, especially with, say, obese patients, where finding those internal landmarks can be more challenging. You need good technique and good people skills.
Right. Okay, so the room's ready. Where does the picture actually form? The image receptors, IRs.
Exactly, the IRs. Our sources mention 4 main types, though some are more common now than others.
Let's hear them.
Okay, the big one today is digital radiography, DR. Uses these solid-state digital detectors. The beauty is you get near-instant images. Can be wired or wireless.
So like a digital camera almost, direct capture.
Kind of, yeah. Then there's computed radiography, CR, that uses these photostimulable storage phosphor image plates, PSP plates.
Sounds fancy. How does that work?
It's cassette-based. The plate inside the cassette stores the X-ray energy after the exposure. Then you take the cassette to a reader and a laser scans the plate, releasing that stored energy as light, which is then converted into your digital image.
Ah, okay. So DR is instant, CR is a 2-step process with the cassette. Got it. What were the other 2?
Fluoroscopic IRs. These allow for real-time viewing, like an X-ray movie.
Oh, right, for watching things move.
Exactly. Guiding procedures, watching barium swallows, capturing full-motion video. Super useful. And then there's, traditional film. Much less common now in most places, but it's still out there.
And sizes, do they vary?
They do. DR systems often use big receptors, like 14 by 17 inches, sometimes even 17 by 17, for good coverage.
Yeah.
CR uses various cassette sizes, but 10 by 12 and 14 by 17 inches are pretty standard.
And it's not just the receptor. There's other gear involved too, right? Like positioning aids?
Oh, yeah. Sponges, blocks, support stuff to help you hold still in the right position. Very important. And grids.
Grids, what do they do?
They sit between you and the IR. They absorb scattered radiation X-rays that bounce off in random directions. Scatter fogs up the image, reduces clarity, so grids clean that up.
Makes the image sharper.
Exactly. And sometimes compensating filters. These help even out the exposure when you're X-raying a body part with very different thicknesses, like a foot maybe, ensures more uniform brightness.
Wow. Lots of little things that add up to a good picture.
They all contribute. Quality image, lowest possible dose. That's the goal.
Okay, so let's move into the power behind the image, the technical factors, the machine settings. This is where the science really kicks in.
It absolutely is. Radiographers control several prime factors. First up, kilovoltage peak, or KVP.
KVP, what's that controlling?
Primarily the energy or the quality of the X-rays, how penetrating they are.
So higher KVP means more punch, gets through denser stuff.
Precisely. Higher KVP, more penetration. But there's a trade-off. It usually means lower image contrast.
Lower contrast, fewer distinct shades of gray, more black and white.
Sort of, yeah. A longer scale of grays, actually, but less difference between them. So KVP affects penetration and contrast.
Okay. What about the amount of X-ray, the overall brightness or darkness?
That's mainly controlled by MAs. It's a product of milliamperage, MA, which is the quantity of X-rays produced per second.
Okay.
And the exposure time, how long the beam is actually on. So MA multiplied by time gives you MAs. That dictates the quantity of X-rays.
Got it. KVP for quality penetration, MAs for quantity blackness.
That's a good way to think about it. And many modern systems use AEC, automatic exposure control.
What's that?
It's clever. There are ionization chambers behind or in front of the IR. When enough radiation hits them to create a good exposure, the system automatically shuts off the beam.
Ah, so it adjusts for patient size automatically.
Largely, yes. Ensures a consistent image density. Super helpful.
Okay. What else? Distance matters, you said. SID.
Hugely. SID, source to image receptor distance. That's the space from the X-ray tube, the source, to the IR.
And why does that matter so much?
Image quality again. A longer SID, like the 72 inches we often use for chest X-rays, actually reduces magnification of the body part.
Reduces. You'd think further away makes things smaller.
It reduces the magnification effect of the diverging beam, making the structures appear closer to their true size and sharper, increases spatial resolution. A shorter 40-inch SID is traditional for most other exams.
Okay, less magnification, sharper image with longer SID. What about OID?
Object to image receptor distance. That's the gap between the body part being X-rayed and the IR.
You want that small.
As small as possible, usually. The closer the object is to the IR, the less magnification and distortion you get. Keep it close.
Makes sense. And the central ray, CR, the main beam.
Yeah, the theoretical center of the X-ray beam. It should always be centered to the anatomy you're interested in and centered to the IR. Usually perpendicular, straight on.
Usually. So sometimes it's angled.
Exactly. You might angle the CR to, say, avoid superimposition, stop one structure overlapping another and hiding detail, or to kind of straighten out a curved bone on the image.
Like projecting through an angled joint space.
Perfect example. Or to prevent shape distortion of a structure that's naturally angled in the body. Distortion itself is just any misrepresentation of size or shape.
And that's controlled by SID, OID.
How parallel the object is to the IR and where that CR is centered. Get those right. Minimize distortion.
There's also SSD, source to skin distance.
Right. Distance from the tube to the patient's skin. This one's mainly about patient dose. The NCRP, the National Council on Radiation Protection, recommends a minimum of 12 inches. Further is generally better for dose reduction.
Okay, another safety checkpoint. And related to safety is collimation, right? Restricting the beam.
Absolutely crucial. Collimation means adjusting the X-ray field so it only covers the area of interest, nothing more.
Why is that so important? 2 reasons.
2 big ones. 1, minimize patient radiation exposure. Only irradiate what you need to see. 2, reduce scanner radiation.
Stuff that fogs the image.
Exactly. Less scatter means a cleaner, clearer image. So good collimation equals lower dose and better picture.
And our sources were really clear on this. Collimating too wide, exposing more than needed, is actually an ethical violation for radiographers.
It is. The ERA Code of Ethics is very specific. You must collimate appropriately.
And just cropping the image digitally later, shuttering, that doesn't count.
Not at all. That does nothing to reduce the patient's actual dose during the exposure. Plus, you risk cropping out something important, leading to misdiagnoses. Legally and ethically risky. Collimation happens before the exposure.
Got it. Be precise at the source. Okay, image captured. Now, making it official. Anatomic markers, R and L.
Absolute requirement. Every single X-ray must have a clear marker indicating the patient's right R or left L side. Non-negotiable.
Why so strict?
Correct interpretation. Imagine surgery on the wrong side because an X-ray wasn't marked properly. And legal reasons, too. The marker has to be physically placed in the exposure field right on the edge of the collimation border.
Physically there, not added later digitally.
Never added digitally afterwards. Huge potential for error, massive legal risks. It has to be part of the original exposure.
Okay. Markers on. Then the radiographer actually evaluates the image before sending it off?
Yes, they perform an image critique. They check. Are the right structures shown? Is the positioning good? No rotation, correct alignment? Is the collimation tight? Is the CR centered properly? Patient ID, date, name or ID number, the hospital or clinic identity. Is the marker placed correctly and readable? Are there any artifacts like buttons, zippers, jewelry, even internal things, sometimes obscuring the view?
So a whole checklist before it even gets to the radiologist.
Exactly. Quality control is built in.
And how are these images usually displayed? For reading?
Typically in what we call anatomic position. That's viewed as if the patient is standing upright, facing you, palms forward.
Okay.
There are exceptions, though. Forearms, hands, fingers, feet, toes. Those are often viewed from the perspective of the X-ray tube, kind of looking down onto them, with the fingers or toes pointing upwards on the screen.
Interesting convention. Okay, so we've walked through the how-to of X-rays, but none of that works without knowing what you're looking at, which brings us squarely to anatomy.
The absolute foundation. You can't position accurately or evaluate an image without knowing your anatomy. Not just names, but locations, relationships.
And thinking in terms of body planes helps, right? Those imaginary slices.
It's essential. You've got the sagittal plane divides the body into right and left parts. Mid-sagittal is equal right and left halves.
Okay.
Coronal plane divides into front, anterior, and back, posterior. Mid-coronal is equal halves.
Front and back, like looking at someone head on or from behind.
Exactly.
Yeah.
Then horizontal, also called transverse or axial, that slices into top superior and bottom inferior parts, like a CT scan slice.
Right.
And finally, oblique planes. Any angled slice. Understanding these helps you mentally visualize how to line up the beam and the IR to see a specific structure without it being hidden by something else.
It's like having the 3D map in your head.
Pretty much. And that map changes depending on the person's body shape, their body habitus.
Oh, right, the 4 types. Sthenic is average.
Hyposthenic is slimmer. Hypersthenic is thicker set, short, wide. And asthenic is very slender, very frail sometimes.
And organ placement changes significantly.
Oh, definitely. A hypersthenic person's stomach might be really high up and almost horizontal. An asthenic person's might be very low and vertical. Lungs, gallbladder, heart, they all shift position depending on habitus. Radiographers have to account for that.
So you adjust your centering based on body type.
Every time. We also use very specific language for relationships. Anterior, posterior for front back. Superior, inferior for headward, footward.
Why is this vocabulary so vital? Can't you just say front?
Precision. Is it the front surface or the structure towards the front? Terms like medial, towards midline, and lateral, away from midline, are unambiguous. Proximal, closer to trunk origin, and distal, further away.
Like the elbow is proximal to the wrist.
Exactly. Or is the ankle proximal or distal to the knee?
Distal. Further away.
You got it. See? Other key ones. Central peripheral, superficial deep, caudad towards feet, cephalad towards head, ipsilateral, same side, contralateral, opposite side. And for hands and feet, palmar, palm, plantar, sole, dorsum, back of hand, top of foot.
Wow. It really is a whole separate language for navigating the body.
It is. Clear communication is everything.
Now let's nail down the radiographic language itself. Positioning terms. There are some key distinctions here, right? Projection, position, view.
Absolutely critical distinctions. Projection describes the path of the central ray through the patient. It's named by where it enters and exits.
So AP projection.
Enters anteriorly front, exits posteriorly back. PA is the opposite. Enters posterior, exits anterior.
Okay. And position.
Position refers to the patient's overall posture, or how a specific body part is placed relative to the IR or the table. Like supine position means lying on your back. Prone is on your stomach.
Got it. So projection is the beam's path. Position is the patient's posture. What's view then?
View describes how the body part is seen by the IR. It's essentially the opposite of the projection. A PA chest projection results in a PA view of the chest.
Okay. The result you see on the image.
Exactly. Keeping these straight prevents confusion.
And it's standard practice to get at least 2 projections, usually 90 degrees apart. What, that 90 degrees?
Because we live in 3D, A single flat image doesn't show depth. Two images at right angles give you that crucial third dimension. Helps you locate foreign bodies precisely, see how fracture fragments are displaced.
Rule out things just overlapping and looking like a problem when they're not.
Exactly. Common projections include AP, PA, lateral, oblique, also axial, where the CR is angled 10 degrees or more along the long axis. Tangential skims a curved surface. And decubitus uses a horizontal beam on a lying patient, great for air fluid levels.
And patient positions, we mentioned supine and prone. What else?
Upright, seated, recumbent, which just means lying down. More specific, Trendelenburg, head lower than feet.
Why would you do that?
Can help shift organs around, maybe fill upper parts of the stomach with barium, things like that. Fowler position is head elevated. Sims position is on the side, one leg flexed up, often used for enemas. Lithotomy is legs up in stirrups.
Right.
Then lateral on the side, oblique, body rotated partway, decubitus lying, horizontal beam, and lordotic leaning backward. Specifically helps get the clavicles out of the way to see the long apices.
So many ways to position someone. And then there are terms for movement, too. For instructions.
Absolutely. You need patients to move specific ways. Flexion, bending, and extension, straightening. Abduction, moving away from midline. And adduction, moving towards midline.
Like lifting your arm out to the side is abduction.
Perfect. Pronation, turning forearm, palm down. And supination, palm up. Inversion, turning foot sole inward. And eversion, sole outward. Circumduction, circular movement, tilt, slanting. And for the foot, dorsiflexion, toes up towards shin, and plantar flexion, pointing toes down.
Clear instructions are key for getting the patient cooperation needed for a good image.
Couldn't do it without them.
Okay, this all relies on the framework. Bones. Osteology. They do way more than just hold us up, don't they?
Oh, absolutely. Bones are amazing. Attachment points are muscles, yeah. Mechanical basis for movement. Protection, think skull, ribs. Body support. Mineral storage, calcium, phosphorus, critical reserves.
And making blood cells.
Crucial function. Red and white blood cells are produced in the red bone marrow. So understanding bone health is vital, and x-rays are fantastic for seeing bone structure.
We've got 206 bones split into axial head and trunk, 80 bones.
And appendicular limbs, 126 bones for movement. Structurally, you have dense, compact bone on the outside.
And spongy bone inside. Like a honeycomb.
Exactly. That web-like trabeculae structure filled with marrow. Bones have a blood supply entering through little holes called foramina.
Yeah.
They're living, dynamic tissue.
How do they develop? Ossification.
Right. Two main ways. Intramembranous ossification. Bone forms directly from membranes. Think flat bones of the skull. This process leads to sutures, those fibrous joints.
Okay. And the other way?
Endochondral ossification. Bone develops from a cartilage model. Most bones form this way. There are primary centers of ossification, starting before birth in the shafts of long bones and in shorter regular bones.
And secondary centers.
Those appear after birth, usually at the ends, the epiphyses of long bones. Between the shaft, diaphysis, and the end, epiphysis, in a growing bone is the epiphyseal plate.
The growth plate.
That's the one. It's cartilage where lengthwise growth happens. It's also a weaker spot, so common fracture site in kids. It fuses, becomes the epiphyseal line, usually around age 21, marks the end of growth.
Bones are also classed by shape. Long bones like the femur.
Short bones, like carpals in the wrist, cube-shaped. Flat bones, like the sternum or skull cap, they have that sandwich structure. Compact bone, then spongy bone called diplo, then compact bone again.
Diploid, got it.
Irregular bones, vertebrae, pelvis, complex shapes, and sesamoid bones.
Like sesame seeds. Small.
Small, oval bones embedded within tendons. The patella, the kneecap, is the biggest example. They protect tendons from wear and tear. Knowing these shapes helps radiographers plan their angles.
And finally, where bones meet, joints. Arthrology. Classified by structure.
Primarily, yes. You have fibrous joints basically immovable, held by dense fibrous tissue, like skull sutures or the syndesmosis between lower leg bones.
Okay, strong connection.
Cartilaginous joints, slightly movable, united by cartilage, like the pubic symphysis between pelvic bones or the synchondrosis of the epiphyseal plate before it fuses, allows a little give.
And the most common, the ones that move freely.
Synovial joints. These are the freely movable ones. They have a joint cavity filled with synovial fluid enclosed by an articular capsule. Often have extra bits like menisci cartilage pads for shock absorption, like in the knee.
Or bursae. Little fluid sacs.
Right, bursae reduce friction where tendons or muscles rub over bone. Understanding joint types is key for positioning. You wouldn't x-ray a hinge joint like the elbow the same way you'd x-ray a ball and socket like the shoulder.
Makes sense.
Yeah.
What are the types of synovial joints?
Gliding or plane joints like in the wrist and ankle, hinge joints, elbow, knee, pivot joints for rotation like between the first two neck vertebrae, C1 and C2, ellipsoid joints allow movement in two planes like the wrist, saddle joints only really at the base of the thumb, and ball and socket, hip and shoulder, widest range of motion.
That covers a lot of ground on the basics. Okay, let's apply this. Deep dives into specific areas.
Yeah.
Starting with the chest, the thoracic viscera. What's in there?
The thoracic cavity is big, bounded by ribs, sternum, spine, diaphragm below, contains the lungs, heart, the great vessels, esophagus, trachea, thymus gland, all packed into the mediastinum, that central space.
And the airway's trachea splits at the carina into the bronchi. You mentioned something important about the right bronchus.
Yeah, anatomically, the right main bronchus is shorter, wider, and crucially more vertical than the left.
So if you inhale something, you shouldn't.
It's much more likely to go down the right side. Clinical significance right there. The bronchi keep branching down like a tree into tiny bronchioles, ending in the alveoli.
Millions of tiny air sacs for gas exchange.
That's where the magic happens.
And the lungs themselves. Apex at the top, base on the diaphragm.
Right. Costophrenic angles are the sharp corners at the bottom sides. Hilum is the medial area where bronchi, vessels, nerves enter and exit. Right lung has 3 lobes. Left has 2. Heart takes up space on the left.
And they're wrapped in pleura.
A double-layered membrane. Visceral pleura clings to the lung. Parietal pleura lines the chest wall. A little fluid between allows smooth movement during breathing.
And the mediastinum holds the heart, vessels, trachea.
Esophagus, thymus, lymph nodes, nerves, fat. It's crowded but vital real estate. A chest x-ray gives you a snapshot of all this.
So imaging the chest. Essential projections, you mentioned PA and lateral are common.
Very common. PA chest is usually upright. CR aimed at T7 vertebra level, shoulders rolled forward to get scapulae out of the lung fields, and that 72-inch SID.
For less heart magnification and exposure on.
Deep inspiration. Hold your breath in. Fills the lungs with air, makes them easier to see. Lateral chest, usually left side against the IR. Arms up. M-P perpendicular to IR, CR at T7, 72-inch SID. Again, full inspiration.
And if someone can't stand, sick patients.
Then we do an AP chest, often supine in bed. IR goes behind them, maybe 1.52 inches above the shoulders. SID might be shorter, maybe 60, 72 inches if possible. Still try for inspiration.
What about seeing the lung cups, the apices? For TB, maybe?
Good call. AP axial lordotic view. Patient leans backwards significantly, angles the clavicles up and out of the way of the apices. CR enters mid-sternum.
And obliques, or decubitus.
Obliques rotate the patient to separate overlapping structures, like the heart from the spine. The tubitus lying down with a horizontal beam is key for air fluid levels.
Fluid side down, air side up.
You got it. Fluid settles, air rises. Need to let the patient stay in position for about 5 minutes before shooting. Let gravity do its work.
Yeah, and evaluating these images, what makes a good PA chest x-ray?
Key criteria. No rotation check. The clavicle ends. They should be equal distance from the spine. Scapulae projected clear of the lung fields. And good inspiration, you should see at least 10 posterior ribs above the diaphragm.
That shows the lungs are fully expanded.
Right. These checks ensure it's a technically adequate diagnostic image.
Okay, shifting down now to the body's core. The abdomen. Abdominopelvic cavity. What's in there?
Everything from the diaphragm down to the pelvic floor, basically. Abdominal cavity proper has stomach, small and large intestines, liver, gallbladder, spleen, pancreas, kidneys, ureters. Pelvic cavity below holds sigmoid colon, rectum, bladder, reproductive organs.
And we use quadrants or regions to locate things.
Yeah, simpler is 4 quadrants. Right upper, right lower, left lower. RUQ, LUQ, RLQ, LLQ. More detailed is 9 regions, epigastric, umbilical, hypogastric, down the middle, etc. Helps pinpoint pain or findings.
And it's mostly lined by the peritoneum.
Right, that double-walled sac. Visceral layer covers organs. Parietal layer lines the wall. The space behind it is the retroperitoneum.
Kidneys are back there.
Kidneys, pancreas, parts of the aorta and vena cava, duodenum. Yep. Key digestive organs. Stomach flows into small intestine, duodenum, jejunum, ileum, then large intestine, cecum, ascending, transverse, descending, sigmoid colon, rectum, anus.
And urinary organs visible?
Kidneys right, usually a bit lower than left because of the liver. Ureters running down, bladder in the pelvis, urethra exiting.
So x-raying the abdomen, common views.
AP supine is the bread and butter, often called a KUB. Kidneys, ureters, bladder. CR centered at the iliac crests. Patient just lies flat.
What about upright?
AP upright abdomen is crucial for looking for free air under the diaphragm from perforation or bowel destruction patterns with air fluid levels. CR is usually centered a bit higher, maybe 2 inches above the crests, to make sure you include the diaphragms.
And if the patient can't stand for the upright?
Left lateral decubitus is the alternative. Patient lies on their left side, horizontal beam. Again, CR about 2 inches above crests. Key here is exposure at the end of expiration.
Expiration. Chest was inspiration. Why expiration for abdomen?
To relax the abdominal muscles and avoid compressing the organs, lets them spread out more naturally. And again, wait 5 minutes in position for air fluid levels to settle before exposure. Dorsal decubitus, lying supine, beam from side, is another option.
And sometimes specific series are ordered.
Yeah, an acute abdominal series or obstruction series often includes AP supine, AP upright or decubitus, and a PA chest upright. The chest view is specifically looking for that free air under the diaphragm. A simpler 2-view abdomen might just be AP supine and AP upright or decubitus.
Technical factors. KVP, MAs.
Average might be around 80 kVp, maybe 10 NAs, but highly variable depending on patient size. Exposure on expiration, remember. And SID is usually 40 inches for abdomen.
Okay, this is where it gets really interesting. Pathology. How diseases actually change the image. This is the payoff, diagnostically.
It absolutely is.
Yeah.
Diseases alter tissue thickness, density, composition. That changes how X-rays pass through or don't pass through, which changes the image appearance. And radiographers need to anticipate this and adjust their technique.
They fall into 2 main camps, you said. Additive and destructive.
Broadly, yes. Additive conditions add density. Increase tissue thickness, higher effective atomic number, more fluid, whatever. They increase X-ray attenuation.
More absorption, less gets through. So the image look.
Whiter, more opaque, because fewer X-rays reach the IR to darken it.
Examples.
In the chest, pneumonia, fluid pus in air sacs, atelectasis, collapsed lung is dense, cardiomegaly, enlarged heart muscle, pleural effusion, fluid around lung, all look whiter, denser.
Abdomen.
Ascites, fluid, cirrhosis, denser liver tissue, calcified stones like kidney stones, bones, osteoblastic metastases, bone-forming cancer, Paget's disease, thickened bone, sclerosis, hardening.
So for additive, you need to increase technique, more penetration.
Generally, yes.
Yeah.
Increase KVP, maybe 515 KVP is a common approach to get through that extra density. Sometimes MAs needs adjusting too.
And destructive conditions are the opposite, less density.
Exactly. Decrease tissue thickness, lower atomic number, maybe air-replacing tissue. They decrease attenuation. More X-rays get through.
Making the image look darker.
Blacker.
Darker, blacker, more lucent is the term we use.
And for these, you need to decrease technique.
Right. Usually decrease MAs. Otherwise, you'll overexpose the area, make it too black, burn out detail.
Examples of destructive.
Chest. Emphysema, enlarged air spaces, less lung tissue. Large pneumothorax, air where lung should be. COPD often shows destructive changes. Abdomen. Bowel obstruction can show large, dark, air-filled loops, though the cause might be additive. An ileus, paralyzed bowel, fills with air. Bones, osteoporosis, loss of density. Osteolytic bone cancer, bone destroying. Osteomalacia softening. Degenerative arthritis can thin cartilage and bone.
Fascinating. Let's look at specifics. Radiographic clues for certain conditions. Chest first. Croup in kids. I can cough.
Yeah, classic sign. On an AP soft tissue neck X-ray, you look for narrowing of the airway below the vocal cords, the subglottic area, due to swelling, edema. Often looks like a church steeple. They call it the steeple sign.
Okay, pneumonia.
Patchy white spots or areas of solidation, opacities where the air sacs are filled.
Tuberculosis. TB. Often in the lung apex.
Can show up as nodules, spots, especially in upper lobes. Sometimes cavities, dark holes where tissue's been destroyed, or just hazy areas. Can be subtle or obvious.
RSV. Respiratory syncytial virus in babies.
Causes bronchiolitis. Often shows hyperinflation, lungs look too big, too black with increased lung markings, looks kind of busy.
COPD emphysema.
Again, hyperinflation, flattened diaphragm because the lungs are pushing down, maybe increased lung markings or loss of markings in areas of destruction, sometimes large bullae, which are big air pockets.
Atelectasis collapsed lung.
Increased density, looks wider in the collapsed part. Might see the trachea or heart shifted towards the collapse as things move to fill the space. Different from pneumothorax.
Right. Pneumothorax is air outside the lung.
Exactly. Air in the pleural cavity. Looks like a very dark area with no lung markings. You can often see the edge of the collapsed lung as a thin white line. If it's large, a tension pneumothorax, it can push the diaphragm down, shift the heart away from the affected side. That's an emergency.
Intrabronchial foreign body. Kid inhales a peanut.
If it's radiopaque, like metal, you see it. If it's radiolucent, like a peanut, you look for secondary signs, maybe hyperinflation of the lung beyond the blockage, or atelectasis if it's fully blocked. And remember, usually goes down the right side.
Pleural effusion fluid around the lung.
Key sign is blunting of the costophrenic angle. That normally sharp corner at the bottom side of the lung gets obscured, looks hazy, or white as fluid fills it up. Large effusions can compress the lung. Best seen on decubitus view, affected side down.
Diaphragmatic paralysis.
One or both sides of the diaphragm look abnormally high up in the chest. Doesn't move properly on fluoroscopy or with sniff tests.
Okay, shifting to the abdomen pathologies. Pneumoperitoneum. Free air.
Big one. Usually means something perforated, like an ulcer or bowel. Best seen with a horizontal beam AP upright or decubitus. Look for crescent-shaped black air under the diaphragm. It's a destructive finding air where it shouldn't be. Surgical emergency often.
Constipation.
Can give a very mottled, spotty appearance throughout the colon due to retained stool mixed with gas.
Kidney stones. Renal calculi.
Most are calcium-based, so their radiopaque show up white. Often seen in the kidney outline or along the path of the ureter, can cause severe pain if stuck. They're additive, more common in elderly males, often lodge at the vesicoreteral junction where ureter meets bladder. Dehydration, diet contribute?
Intussusception. Bowel telescoping.
Yeah, one part of the bowel slides into the part next to it, like a telescope closing, creates obstruction. Most common in young children. Can sometimes see an air-filled, coiled spring appearance, considered additive due to the bunched-up tissue.
Volvulus. Twisting bowel.
Very serious. Twisting cuts off blood supply, can lead to bowel death quickly. Shows characteristic, massively dilated loops of bowel, often in a coffee bean shape. More common in adults, sigmoid colon, but can happen in infants too.
Abdominal aortic aneurysm. AAA.
Dilation, bulging of the main artery in the abdomen, often asymptomatic unless leaking, rupturing. Might see calcification in the wall of the aorta on X-ray if it's chronic. Large ones can be felt as a pulsating mass. Technically neither additive nor destructive unless calcified, then it's additive.
Bowel obstruction in general.
Blockage. Causes backup of gas and fluid proximal to the blockage. See dilated loops of bowel, often with multiple air fluid levels on upright or decubitus ways. Usually considered additive overall because of the increased bowel contents.
And tumors.
New tissue growth usually appears as a soft tissue mass displacing normal structures. Typically additive as its extra tissue density.
Wow. We have covered a ton of ground today. Seriously, from the basic physics, the X-ray machine itself, through all that anatomy.
Body planes, positioning terms, bones, joints.
Yeah, and then seeing how all these different diseases leave their visual signatures on the images, it really gives you an appreciation for the blend of skills involved.
Technical skill, deep anatomical knowledge, critical thinking about pathology and image quality. It's a lot that goes into being a good radiographer.
So for you listening, this isn't just about memorizing terms. Hopefully, it's about appreciating the precision and expertise that goes into capturing those internal blueprints of our bodies.
Yeah.
They're so critical for accurate diagnosis, for effective treatment.
Absolutely. These images guide so much of modern medicine.
So here's a final thought to chew on. The next time you see an X-ray, maybe your own, maybe just in general, think beyond just what it shows. Think about how it was made. Think about the radiographer, the silent detective work, every decision from positioning to exposure, all aimed at revealing those hidden stories inside us.
It's a blend of art and science, truly.
Definitely. And it makes you wonder, what other medical imaging technologies out there rely on a similar intricate blend of art and science to show us the unseen? Something to think about.